And don't go wait until the morning. You never know when it is over. All that I know is we'll get older. So let us dance this night away. Our bodies move to the groove and the light that flickers. We get lost in the crowd, it's getting thicker. But get away from the drinks and chatter. Haven't said a word, but it doesn't matter. Feel the air get thinner. I'm standing in a blurry dream. No one else can see us. Live your life within the moment. And don't go wait until the morning. You never know when it is over. All that I know is we'll get older. So let us dance this night away. Feel the air get thinner. I'm standing in a blurry dream. No one else can see us. So let us dance this night away. Live your life within the moment. And don't go wait until the morning. You never know when it is over. All that I know is we'll get older. So let us dance this night away.
Welcome. It is that time for Ask Dr. Geier Live, our first Ask Dr. Geier Live of 2023. Wherever you're watching, whether it's here on YouTube, whether it's Twitter, whether it's Facebook, whether you're somewhere warm, somewhere cold, somewhere rainy, somewhere snowy, I hope you're making today your masterpiece. My name is Dr. David Geier, triple board certified orthopedic surgeon, sports medicine specialist, and anti-aging and regenerative medicine expert. I help you feel, look, and perform your best regardless of age or injuries. Very, very excited to be back. I took 3 weeks off, the first 2 weeks toward the end of 2022 for holiday breaks and sort of recalibrating and all of that. And then this past Friday I was traveling, so I apologize. For those of you that have not seen this, especially the folks on Facebook and Twitter, because I used to just do this on YouTube, and I may still go back to that at some point, leave your questions in the chat. I will answer them as long as there are questions here. If you come later and see it, unfortunately, I won't be able to do that. So leave those, especially if you folks on YouTube, leave them in the chat, not in the comments below. The chat is what I can see. Also, I would love for you to leave your first name and where you're located. Always helps me sort of know who people are, where people are, things like that. It's just more fun than silly face 402 or something like that. But, it is what it is. Also, please remember, I am not giving you specific medical advice. I haven't seen you. I haven't examined you. I haven't looked at x-rays, MRIs, lab studies, any of that. So I cannot give you any medical advice. Legally, I can't give you medical advice. I'm not your doctor. You're not my patient. But because this is meant for educational and informational purposes, you can take that information, then when you go see your doctor, understand a little bit more about what he or she is saying, maybe say, hey, what about this treatment with your doctor? If you would like to come see me in Charleston, South Carolina, it is beautiful. It is 59 degrees and perfectly sunny, so it is a great place to be this time of year, really all year. You're welcome to come do that. I will, at the end of the show, tell you how you can come see me. The information is also in the description below. Like I said, I'll stay as long as there are questions. If there aren't questions, then I won't do it. But first one we've got today, thoughts on shoulder impingement, exercise, stretches, meds, supplements. Okay, good question. Shoulder impingement, before I talk about treatments, it's a condition related to pain as people reach up overhead. That rotator cuff gets sort of, not inflammation, the whole tendonitis or bursitis has been a little bit debunked. It's more of what we call a tendinopathy, so you get an intrinsic degeneration within the tendon, but typically it hurts reaching up overhead, reaching out away from your body and reaching behind your back, where your rotator cuff is put in positions of weakness, positions of pain, and those activities tend to hurt. Fortunately, almost never needs surgery, which is a great thing. In fact, I don't know that going in and cleaning up the bursa, smoothing out what's called the acromion, the tip of your shoulder blade, is terribly helpful, honestly. So, yes, you do try to get it better. First and foremost, as SNC Nutrition suggests, are exercises. I'm a big fan, honestly, of doing it with physical therapy because I'm sure you could go on YouTube. I don't have a band around, but I could show you rotator cuff exercises. What I've known, and I've talked to a lot of physical therapists about shoulder impingement exercises, specifically rotator cuff exercises, is if you just go online and get them, or you get a sheet, and then they come in to a physical therapist or a doctor and you say, hey, show me the exercises, they do them completely wrong. They're flailing their arms around and doing all this kind of stuff, and they end up making the problem worse. Exercises can be very, very effective, but you have to do them correctly so that you work the muscles that you're intending to work. That's why I'm a big fan of either one, working on a regular basis with a physical therapist if you have shoulder impingement, or at least at the bare minimum, go see your physical therapist once, learn the exercises, make that physical therapist show you exactly how to do them, and you do them in front of him or her so that physical therapist can correct your form, and it'll tend to do a whole lot better. As far as other things, I am not a fan of cortisone shots for shoulder impingement, the old tendonitis, bursitis. Multiple studies have shown problems with that. One, weakening the rotator cuff tendon, making it more likely to tear, increasing the rate, if you do need a rotator cuff surgery, increasing the rate that repair fails. I just don't feel like that's a good idea. It's not fixing the underlying issue. It's just a painkiller. At the end of the day, it makes the shoulder, I would argue, worse than it does better. There are other treatments that are more experimental that have been looked at. Things like injecting PRP, platelet-rich plasma, into the shoulder has thought to be very helpful. I have not seen any studies on use of peptides, things like BPC 157, maybe a thymosin beta 4. That could be something you could consider trying if you're really trying to avoid surgery, avoid cortisone shots. Having said that, again, I don't have a lot of experience and I haven't seen any research looking at peptides for that particular issue. It makes sense that potentially a BPC injection, especially if you can put it fairly close to your shoulder, just under the skin, that actually might be fairly effective, but I haven't, that would have to be something that, patients try and see how it goes because there just aren't studies on that. And again, not a huge fan of surgical treatment for shoulder impingement, typically, unless there's something else going on, typically not necessary. So SNC, I hope that helps. Bina, who has been here before, and I am grateful for that, have had biceps tenotomy, tennis elbow surgery last year. Biceps and elbow still hurts a lot. So the biceps tenotomy, and I don't, to be fair, know anything about you demographically. I don't know how old you are or what kind of activities you do. Biceps tenotomy can be a good surgery. In my experience, that was a better surgery for people 60 and older that are getting a little less active. In younger active people, it seems like detaching it and then reattaching it, what's called a biceps tenodesis, could be a better option. But again, without knowing that particular circumstance, your circumstances, I can't really say. But a lot of times when you do a biceps tenotomy, where you cut that biceps tendon up at the shoulder, you can get some muscle achiness with activities, especially if you're really active. That's not uncommon. As far as, what was the other surgery? Tennis elbow surgery. That's just a long recovery. I don't know when last year it was done, but typically you have to do a fair amount of work to get that strength back. That surgery has good success rate, somewhere around 85%. It's not 100%. I always felt like it was something worth doing if nothing else was working, but I wasn't super excited about the long rehab and how people still felt it sometimes. I always felt like the surgery, it left a little something to be desired. Not to say that you can't have a great outcome with it, but again, with both of those problems, given, all right, the surgery's already happened, big proponent at that point of things like physical therapy. That's where sometimes peptides to get the muscles in that area stronger can be helpful. Something like a CJC, something like BPC, which isn't really going to get the muscles stronger, but just overall can help with healing and decrease or improvement of muscle, tendon, ligament, fiber healing. So hope that helps. I don't know that I'm going to try to pronounce this. Karanvir? I apologize. I had knee patellar tendonitis. I can cycle easily. Can I start rope skipping, cycling for 3 to 4 months? Yeah, I don't necessarily worry that certain exercises, sports, different physical activities are going to make patellar tendonitis damage worse. And yes, it sometimes is an inflammation of the patellar tendon below your kneecap, but a lot of times what it is you get a small area of degeneration within the tendon, similar to what I talked about with the rotator cuff earlier. With the patellar tendon, what tends to aggravate it are things like jumping, especially landing from a jump. So that could potentially bother somebody with patellar tendonitis more than cycling would. Having said that, I don't expect that it would do any structural damage. It may aggravate it again and set you all the way back. So I would say start light, maybe a short period of time, see if it's uncomfortable. Then a couple days later, do it for a little bit longer. A couple days later, do it for longer, and get your knee ready for it. At any point, if there's that pain again, I back up. There's a lot of effective treatments for patellar tendonitis. That's another one. Peptides can be helpful. Another PRP can be really helpul. The one that I would pay attention to is shockwave treatment. That can be really effective for patellar tendonitis. I will tell you, as someone who has done that with several patients with patellar tendonitis, it's probably not the most fun the patient has had for those 12 minutes or so, but it gets better the more you do it. But when you do the shockwave close to bone, it can be a little uncomfortable, but works really well. Usually once a week for 3 weeks or 5 or 6 weeks. Good experience. Bina says 47 years old. Okay, good. All right, where are we here? Lydia says, right knee meniscus repair 5 months ago. Walking slowly as the knee locks sometimes. Doc says that it's scar tissue. Physio, not much improvement. What can be done and how long before it goes away? It's kind of tricky, and what I don't know, and this is not a criticism. Lydia says right knee repaired my right knee meniscus. Maybe where you are, this is not the case. In the United States, 9 out of 10 people that come in and tell me they had meniscus repair surgery did not actually have a repair, meaning the surgeon went in with stitches or anchors and sewed it back together. There are those types of surgeries, but they're typically teenagers, very young adults, 20s, maybe early 30s, because they're the types likely to have a meniscus type of repair, the type of meniscus tear that actually can be repaired. And you'll know you have a meniscus repair, one, hopefully the surgeon shows you the pictures showing the stitches, but more importantly, they'll almost always make you non-weight bearing on it for minimum of 4 weeks, usually 6 weeks, sometimes more. And a lot of times they will put you in a certain type of brace that limits how much you can bend your knee for 4 weeks or 6 weeks, something like that. Whereas what most people have, 85% of meniscus surgeries are not repairs. They're what we call partial meniscectomies, where the surgeon goes in and trims out the inner part of the meniscus tear. There's no real restrictions in terms of weight bearing, bending your knee, much quicker recovery. But the downside of trimming part of it out is that you lose some of that shock absorber, much more likely to develop arthritis down the road. Having said that, the vast majority of meniscus tears, especially as we get older, are not repairable. They won't hold the stitch. The blood supply to that area of the meniscus where the tear is poor, and a repair would fail. So that's when you do that. As far as if you truly had a meniscal repair, two things. One, yeah, scar tissue, I guess, could be part of it. By 5 months, the meniscus repair should be getting relatively close to being complete if it hasn't already. So you could repeat an MRI. The test that I would order personally if it was my patient would not be a plain MRI. It would be what's called an MR arthrogram. A lot of times on a plain MRI, it's probably more than you want to know, but where the repair won't look like normal meniscus. It'll have sort of a different appearance, and you don't know if that's a new tear or a maintenance of the tear that was there before, or is that just healing tissue that just looks different than normal meniscal tissue. And so the better test, I would argue, is what's called an MR arthrogram, where the radiologist injects a certain amount of fluid into your knee and then does an MRI. And the purpose of that fluid is to travel into all around the knee. It gets to the meniscus, it gets to the tear, and if it's still torn, it'll go up into that tear and demonstrate that it's not completely torn. Some people say you should do that 6 months after surgery if it's not doing well. Some people might do it earlier. Some might say do it later. That is a little hard to say, but that would be the other thing I might look into. All right. Yeah, so I hope it's a she. If it's not a she, I apologize. Why are you not popping up on the screen here? Well, it says, there it is, brace for the first 6 weeks. So that very likely is a meniscus repair. It's just in the United States, I see that, like I say, if 10 people come to see me as a patient and they've had a meniscus surgery in the past, they'll tell me it's a repair. 9 of them did not have meniscus repairs. It's just, it makes them feel better. I don't actually know why either the patient had it in their head that they had it repaired or the surgeon. I don't know where that comes from, but it's very, 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 very common. All right. RC MacGyver. Oh, Chris in Saskatchewan. Very cool. Dislocated kneecap twice, November 29th. Something fell, ice, impact my kneecap, now extreme pain when I squat and pops. So when you dislocate your patella, and I'll have to show with the model. Get my knee model here. So the patellar runs in this groove, the trochlear groove of the patella. And when it pops out of place, one, you tear that retinaculum that holds the patella in place. But more importantly, what a lot of times people can do is knock a piece of bone and cartilage either off the undersurface of the patella or in that trochlear groove, and that can be a source of pain. And so that's where sometimes an MRI can be very helpful to see if that's the case. If there's not what we call an osteochondral fracture, you knock a piece of bone or cartilage off, then typically the problem with patellar dislocations is not pain, it's that it's more likely to keep dislocating. And albeit there's no absolute rule about this, but back when I was doing lots of those surgeries, because I was mostly taking care of youth athletes, high school athletes, those levels of athletes, those age groups, is that after 1, you try to rehab them, but after 2, it starts being more and more likely that it's going to come and need surgery. But I do feel like it can be important, especially many weeks and months out, to figure out where the pain is coming from. That, I think, would be an interesting question. Lydia, you're very, very welcome. Mike, if I can get this on the screen, from Vegas, always enjoy watching these videos. I appreciate that, Mike. I actually had a chance to go to a conference in Vegas in December, but I couldn't make it, just had a rough schedule, but I may try to get there this December for that conference. Very, very excited. I'll stick around for a few more questions if anybody has any. If you do want to come see me in Charleston, South Carolina, no, I don't do telehealth where you stay where you are and just consult me and then I ship you medication. Much of what I do, especially because I treat arthritis so much and try to help people avoid joint replacements, can't be done virtually. So you have to come at least once to Charleston, but trust me, you'll love it. The information for that is below drdavidgeier.com. go to the contact page, fill out that form. My assistant and I will get in touch with you and go through what we do, what type of practice it is, all sort of the ins and outs, and help set that up. Literally a third of my patients are not here in Charleston, so lots and lots of people travel, and I would love to do that, especially those of you with knee arthritis, and I'll start talking about that more in the next couple weeks. All right, last couple, and then I need to go. How long did total knee replacement last? When you know, I think you may have asked me that a couple weeks ago. The surgeons will tell you, the joint replacement surgeons say they have survivorship data for 20 to 25 years. There is no guarantee of that, not just in terms of wearing out, but you can have another surgery for lots of reasons. But that is the data that they're giving, is that they have survivorship data on the new prostheses for, those are the components, the metal and plastic, that can last 20 to 25 years. But that also tells you why you should try to avoid getting it in your 40s and 50s if you can, because you're very likely going to outlive that metal and plastic. And then that revision joint replacement is a monster surgery, much bigger than the original knee replacement. So for what that's worth, I try to help people avoid knee replacements in the first place. That's become my calling card here in my practice, as so many people come to me to try to rebuild cartilage, try to minimize the damage so that they can continue to play sports, they can continue to exercise and not need surgery, whether that's joint replacement or the arthroscopic cleanup surgeries, which do absolutely nothing except make the problem worse. So if you have arthritis, I would love to talk to you more about it. Mike, torn ACL damaging my knee more and more if I don't get surgery. That's a fantastic question. Not that all of these haven't been great. The problem with an ACL, and this depends a little bit on age and activity level, but the problem with an ACL is not pain. It's not stiffness. It's not swelling. Those all eventually return. The problem is stability. Basically, your knee can shift out of place when you, and not your kneecap, like the whole tibia shifting out from under your femur, when you run, plant your foot, change directions, when you land from a jump. And so it makes it very, very difficult to play sports. Some people even get those instability. They get their knee to buckle even with daily activities. That's where it becomes a problem. If somebody's knee is actively buckling and giving way with sports, with exercise, with whatever, then yes, it is doing more harm. The more that slides out of place, the more damage there's going to be to the bone and cartilage, the much quicker the arthritis is going to be. The ACL reconstruction surgery does not prevent arthritis, but it does at least decrease the risk of it, but it's still significantly higher than if you had never torn your ACL at all. So most sports medicine orthopedic surgeons, we talk about surgery for ACL injuries. If you are not terribly active, or for some reason it's not giving way, it's reasonable in my opinion to try to go without it. I just haven't seen that many people where that went well. All right, Felicity. Got in an accident, shattered my humerus, radial nerve damage, surgery week after the accident, metal bar screws, don't have all my movement back yet, start PT. No, I feel like that is she asks if there's anything to know. It's getting your motion back, especially your elbow motion. Elbows get very stiff very quickly, so you really want to work on getting it all the way straight, especially. Obviously falling within the parameters of what your surgeon feels comfortable. The radial nerve, if that was injured, is you just assuming the nerve wasn't cut and you had to have a repair, but it was just stretched by the fracture, then you just have to wait. And that can be really aggravating because you can't extend your wrist, extend your fingers, so that can take a long time. But it's patience as much as anything, and I hope that goes well. Come back on subsequent Fridays. Keep me informed on how that's going. All right, I am going to stop with that question. Again, if you want to come see me in Charleston, South Carolina, the information is in the description below. I would love that. Triple board certified orthopedic surgeon. I can talk to you about all kinds of treatments for your orthopedic injury, not just cortisone, physical therapy, and surgery. So very, very excited. Back on schedule now. We should be doing these most every Friday. So I'm very excited to help any way I can. Again, it's not medical advice, but I do try to give you information that helps you make decisions with your doctor that is best for you. Very, very excited to be back in 2023. I hope you're off to a great start of the year, and I will see you right back here next week. Have a fantastic rest of your day and your weekend.